But I think we can take 5 or 10 minutes to just to have some a few questions. So I'd like to invite all the speakers back. Okay, so does anybody have any questions? I think it's been fascinating this afternoon to hear not just the results of some of the research that we've heard about, but actually the process of research and also some of the impact that it's made. So anybody like to kick off? Oh, that's good. That means I get a chance. Excellent. So,
Karen.
Sorry, did I miss someone? Joe. No, let's go that way, right at the front. I'll fit mine in if there's time. Otherwise, I'll get you later.
Well, fascinating talks from different perspectives, all of you. Thank you very much indeed. You've really enhanced today. When you get into health inequalities, it doesn't take long before you get into moral philosophy. And I think particularly in your talk, Susan, you reached that. You talked about frameworks for alternative social value judgments. I'm wondering if you feel able to expand on that at all.
I guess that's a very broad question, but in terms of alternative value judgments, I think that the ones that we tried to draw out, well, we tried to design the framework to make sure that they were explicit, so that they weren't hidden in the methods. And one of the things that's particularly challenging when you're talking about inequalities is you have to, in this type of framework, is we quantify them. So we apply a measure to say how big the difference is in the inequality. But those measures aren't value-free. So if you are describing the extent of the variation, you can describe it in different ways, whether you're focusing on relative inequality or absolute inequality. You can look at different measures like a Gini coefficient, for example, but that applies a particular weight to changes in health at different points in the distribution, so according to how people are ranked or where they lie. So there is a value judgment in terms of just merely summarizing the extent of inequality in a single number. So we have done, we did a bit of work. We were also interested in measures that were compatible with the type of cost-effectiveness analysis that we were doing. But we tried to do a bit of work to expose that. One of the measures that we have been using, that we like to use, is an Atkinson Social Welfare Index that you can inform with an inequality aversion parameter. This allows you to summarize the impact of an intervention in terms of overall health and changes in inequality, and you can elicit from members of the general public their inequality aversion, which is the extent by which the value of that health gain is reduced by inequality in the distribution. And you can report this in different ways. You can say what that implies for how they weight get health gains to particular members, disadvantaged groups versus advantaged groups. Matthew Robson is here, sat in the audience. He did a piece of work on this elicitation exercise in the UK as well. So, yeah.
Thank you.
Thank you. Sir Michael, here on the front row, please, just there, in the middle.
Thank you. Sanjoy greeted me as I came in, and it relates both to what Sanjoy said and what you were talking about, Susan. Thinking about distributions globally. The first time I met Sanjoy, I had just heard a Chicago economist talk about willingness to pay methodology, and I'd never heard that before. And he said, yeah, it's pretty simple. You see how much somebody's willing to pay for a television, then you know how much they value the television. Same with a year of life. If they see how much they're willing to pay for another year of life, then you know how much they value it. I'd never heard this before, and I said to him, you mean a rich person's life is more valuable than a poor person's life? Yeah, of course. And I said, Indians their lives are worthless, is that right? If they're on $2 a day and they can't pay much? He said, no, Indians don't value their lives. Then I met Sanjay, and he told me that during the smallpox eradication campaign, people were willing to go without food for 2 days to get their children immunized against smallpox. So then I went back to Chicago, and Gary Becker, a Nobel laureate, and I said I'd met an Indian historian, and I told him that the news from Chicago was that he didn't value his life. And he got an expression on his face that said, that is what we think, but I would rather you not have put it quite so bluntly. So how do you take the inequality? I mean, I liked very much what you said, but if now apply it to Sanjay's concerns, how do you do it globally?
So we haven't currently looked at distributing resources across countries. We've looked at how you would use a set of resources within a country. So we've looked at this within the UK, and we've also looked at it within Malawi, for example. And we haven't looked at it from the view of how much you should be spending on healthcare. That's kind of a level up from the kind of questions that we have been asking. So within the UK, we have a budget for the NHS, and that determines the kind of marginal product, how much the NHS is generating, how much health it's generating for every additional amount of pounds we put in there. And there's an estimate that for roughly every £13,000 you increase NHS expenditure, you'd get an additional year of healthy life. In Malawi, given the amount of resources that they're dedicating to health at the moment, there's an estimate that the measure is in terms of a healthy life year, in terms of DALYs, that it's one DALY averted for every $61 that is invested. And so there's very different resource invested in those two different countries, which means the marginal product is very different. How much you should be spending, the opportunity costs in terms of spending more on healthcare fall on other non-healthcare things like education or defense and those kind of things. So we haven't applied it to a cross-sector like that. But within the sector, we can look within the Malawi health sector, for example, when they're designing their health benefits package, which interventions should they include? Should they just base that on ones that would improve population health by the greatest degree, or does it change the types of interventions they'd include if they prioritize health inequalities as well, which they do in the health sector strategic plan. They stated that they wanted to also take into account equity impacts of their intervention selection, but they lacked information on which to base those choices. So hopefully these types of methods can provide that type of information to allow them to take those into account. But yeah, so we don't use willingness to pay for a healthy. We look at how much you are actually paying to generate a healthy life year within each of the health systems.
Thank you. Well done, Susan. I think it's a nice example of how the Universities of York approach to health economics might differ a little bit from the University of Chicago. I think how Susan describes this really well is how these kind of methods can be used across the world, both within very different settings and healthcare systems. But also, I wonder whether there's a role for international organisations, for aid organisations, to start thinking about where they get the best bang for their buck, not just in terms of effectiveness, but in terms of reducing inequalities as well. So if I were the Gates Foundation, or perhaps even the Wellcome Trust, we might start thinking about using these kind of approaches too. Other questions? Yes, just up there.
I hate to mention the B word, which in this case will be
no,
Babylon healthcare, not the other one.
Okay.
But how do you see digital health helping expand reach into emerging and developing markets and countries and helping address inequalities?
So, who wants to kick off with that one? Go, Cameron, go for it.
So I think you're on the money there. Digital market has a huge potential. I think there was a few years ago, time came when the number of mobile phones increased the number of population in the world. Almost everyone has got a mobile phone, and already WHO has got a program called Be Healthy, Be Mobile, which is working on a number of areas, including cancers and diabetes and tuberculosis, using mobile SMS messaging. Voice messaging is being used. And now as smartphones are becoming very popular, and in fact in India you can buy a smartphone for a much cheaper price than you would buy one here. So I'm in no doubt that there's a huge potential for that.
Sanjay?
So some of the biggest threats to public health right now come from digital health as well. So anti-vaccination movements. The problem is that the international and national response, or the national response in partnership with the international bodies that want to make fighting anti-vaccinationist movements a priority, tends to be in English. So if you want effective digital health, you have to embrace multilingualism. You can't fight in a country like India with more than 30 languages, messaging that scares parents into getting people immunized in 30 languages with one language that only, I would say, 50% of the population is literate in. And even if you look at the Kerala model where there's 100% literacy, that literacy is in Malayalam, not English. So you'll have to get out of an English-speaking mode. So maybe we need to discuss what digital health is called in Hindi, and then you can talk to Indian government using that word, and then you'll get enthusiasm.
It's a good point, and it's interesting just how language evolves, I think, on the internet, on Twitter and that kind of thing. The anti-vaccine movement becoming increasingly referred to, at least on my Twitter feed, as pro-plague.
Massive danger.
Yeah, but turn it into pro-plague, and then let's spread that movement instead. One more question, if there is a burning one. Otherwise, we can go to coffee. Susan, just down here.
Something contentious. I've seen this graph many times. I've seen this healthcare graph many times about the life expectancy of people, and it just struck me. It starts in 1980, and what happened in 1980? They shut the asylums. And it's since the closure of the asylums that the gap between those who have a serious mental health and those who are the normal population, let's say the general population, I'm not sure they're normal, that's what's happened. And I just wondered whether it's actually been government policy that is actually killing people with serious mental illness.
Rachel, I'm looking at you for that one.
No, it's just a quick conversation point. I mean,
Yeah.
we know that community mental health wasn't implemented because all those NIMBYs didn't want halfway houses. There wasn't enough money they sold off the mental health hospitals for housing and some very nice headquarter buildings. So it didn't actually go back into mental health services. There wasn't actually a mental health community provision. And we all know now you've got to be really, really unwell, and that's incredibly unwell, possibly in A&E, to get any help at all. I'm just wondering whether the beginning of the end was the dismantling of the asylums.
Anyone from the audience want to have a go at that one?
I mean, I can get it. So Najma wants to come in, but I mean, I can get us started. I think that one of the interesting things is we don't really understand what's happening here. That's one of the reasons why we're so keen to do research in this area, because we need to understand what the factors are that are precipitating this kind of decline. And I suspect it's multifactorial, but I'm sure that they're all related. Well, that's just when the graph started. But Najma,
we should get a longer time series and check this.
I was going to say, yeah, it's probably multifactorial, not completely understood, but I think along with closing of asylums, there was an expectation that funding would be invested in community services, and that hasn't happened.
Exactly.
So it hasn't kept pace. So actually overall, I don't think you can say it's the closing of asylums per se. I think, we need to invest more in those community services. The other thing is where that graph stopped, actually, if it carried on, the life expectancy is increasing now. Since it was 2010, it stopped.
Yeah.
But it's not increasing at the same pace as the general population. So the gap is still increasing.
I think some of the examples of health inequalities that we've seen today, both between mental and physical health, nationally and globally, it really does highlight the work that we've got to do, not just on improving overall population health, but on working harder to make sure that that improvement is distributed more equally. So let us break for a coffee. Please, can you all be back in the auditorium by 3:30 when we have our final keynote of the day from Professor Sir Michael Marmot? Can I, before you go, remind you to have a look at the 360-degree auditorium, and can you thank the speakers this afternoon?